BTK stands for Bruton's tyrosine kinase. This is a very important molecule because it is present on B cells and myeloid cells, and it plays a very important role in mediating proliferation, activation, and other functional activities of B cells and myeloid cells. For example, for B cells, antigen-specific activation of the B cells triggers a cascade of events that culminates in the activation of BTK. When the B cells are activated, this results in better antigen presentation, proliferation, and production of antibodies. So you would want to block BTK because of that reason. For myeloid cells like macrophages, the Fc receptors, upon contact with immune complexes, also trigger a cascade of events that also highlights the role of BTK in the activation of these myeloid cells, actually impacting the differentiation of myeloid cells going from an M1 pro-inflammatory phenotype towards an M2 anti-inflammatory phenotype. So B cells and myeloid cells are well known to play a key role in the pathogenesis of multiple sclerosis. So it follows that you would want to inhibit the activation of BTK in order to tackle the immunopathogenesis of MS. So we have recently culminated a phase 2 study of evobrutinib in patients with relapsing forms of MS. In this study, 267 patients were treated with evobrutinib 25 milligrams every day, evobrutinib 75 milligrams every day, and evobrutinib 75 milligrams twice a day, and compared to placebo, which was also given for 24 weeks. That was the time that the primary endpoint had to be analyzed at. And then the patients who had been on placebo were switched to 25 milligrams orally every day. All the other patients in the other arms continued on their original dose. There was also an arm of patients who were on dimethyl fumarate, and this was at the standard dose that is approved for this agent in treating relapsing MS. So the population of patients, because it's relapsing forms of MS, included patients with relapsing remitting MS and also patients with secondary progressive MS that were still having relapses. So this led to a population of patients who, as compared to the typical RMS study, had patients with a little higher age, also a little higher EDSS because they were a little more advanced. Actually, about 13% of patients that were included in the study had SPMS with relapses. So this is just important information to take into account when analyzing the results. The primary endpoint of the study was the total or cumulative number of T1 gadolinium-enhancing lesions going from weeks 12 to 16 to 20 to 24. And it was shown that there was a statistical significant reduction by evobrutinib compared to placebo. We looked at other endpoints, including annualized relapse rate, proportion of patients free of relapses, and other MRI endpoints, as well as EDSS. Of course, this is a phase 2 study with a limited number of patients. When we do these phase 2 studies, we are trying to look not only for statistically significant results, but also for trends that may give us a sense, an overall sense of the benefit risk of the product that will help us make the decision if we want to go into larger phase 3 trials. So I'm very confident that we have actually achieved this type of results that allow us to move into further development of evobrutinib in RMS. We are very excited about evobrutinib in relapsing MS and also for other indications. And this excitement stems from the fact that this drug does not lower the lymphocyte counts. It doesn't affect the white blood cell counts, as opposed to other therapies that are currently being given in MS, some of the other therapies. And this is important because the fact that it doesn't affect the lymphocyte indicates that it may have lower risk of infections and a lower risk of other complications, such as malignancies. In fact, in the phase 2 study, of course, it was a small study, but in this phase 2 study, we didn't see any opportunistic infections, we didn't see any lymphopenia, and we didn't see any malignancies with evobrutinib. So there's still a lot of unmet need in MS, especially for oral agents. So evobrutinib is an oral agent. It may be taken, but aside from what we've seen so far, which is some incidence of ALT elevations primarily, the drug has been very highly tolerable or tolerated. So we are very excited because it can not only be used in theory for relapsing forms of MS, but also for other types of MS. And this is something we are actively entertaining. And we have 2 other trials ongoing, one for lupus and another one for rheumatoid arthritis. So we believe that evobrutinib has a very high potential for treating progressive forms of MS and also other autoimmune diseases. And the main reason is that it has this multimodal mechanism of action. It affects the function of B cells and affects the function of myeloid cells, but it has a very short half-life. This means that if you remove the drug, the cells may recover their function very quickly. And this is in case the patient has complications like infections, which, by the way, are very common in patients who are immunosuppressed because of these autoimmune disorders and the drugs that they have taken. So because of the mechanism of action, because of the fact that it's an oral drug that is highly tolerated, because of the way we are designing our clinical studies in order to mitigate for the liver enzyme elevations, including some monitoring and stopping rules, we are very confident that we can achieve further development of evobrutinib in this indication.